Okay, good evening. Welcome to this session. We have 9 presentations, and each presenter will have 5 minutes to make the presentation and 2 or so minutes for discussion. So we will start. I want to check whether Saim Adil is here. You're here. Can you just come over here? This is yours?
This one.
Okay.
How to open this?
Okay. You have 5 minutes to present your work on the outbreak investigation of brucellosis at the semen production unit in Pakistan. Welcome.
Good evening. Brucellosis is a highly contagious bacterial zoonotic disease. Infected animals are source of infection for human. Research studies have indicated a brucellosis prevalence of 6.9% in animal handlers. This outbreak investigation was done in response to a report received from Supervisor SPU on 21st August 2017 with objectives to estimate magnitude of the outbreak, to identify possible risk factors, and to recommend control measures. SPU has a large setup with an animal population of 600 and staff strength of 86 workers. A descriptive study followed by case control study was conducted from 22nd August 2017 to 25th September 2017. Serum samples were collected from all the staff members, all male animals, and semen samples were also collected from adult male animals. A case was defined as a SPU worker with intermittent fever, headache, and positive for Brucella antibodies on indirect ELISA testing from 21st August to 25th August 2017. A control was without symptoms and negative for Brucella antibodies. A total of 7 human cases were identified. All of them were male. They were working there for the last 7 to 12 years. An overall attack rate of 8% was observed among the SPU workers. Occupation-specific attack rate was highest among semen collectors, followed by 25% in AI technicians, 11% in animal handlers, and 9% in semen processing lab staff. First 2 cases reported on 21st August had symptoms of intermittent fever since 18th August, and last case of brucellosis was identified on the basis of symptoms on 25th August 2017. Occupation of the worker and non-adherence to personal protective equipment were found to be significant risk factors associated with brucellosis. On the basis of research, it was concluded that possible cause of human outbreak was exposure to contaminated semen. Animal handlers and semen collectors not using gloves, masks, or gumboots were more probable to get brucellosis infection. These are few pictures supporting our conclusion. The worker is collecting semen, and while deviating the penis, there are spillage of semen on pads. Second worker is washing pads with naked hands, and the collected semen is being transported to semen processing lab without cap, facilitating aerosol infection. Routine screening of animals, vaccination, and culling of confirmed cases was recommended. Workers were advised to use possible protective measures. Now the livestock department has officially notified screening test of animals for brucellosis and bovine tuberculosis, vaccination of male calves, registration of SBUs and breeding mares, and awareness campaign on zoonosis has been initiated through a mobile training bus at division level in Punjab. Thank you. I think I'm in time.
Well done. Well done. I think those with questions should walk to the microphone, line up so that we know how much time we have. Just maybe to start the ball rolling, clarify for us whether there hasn't been any national program of vaccination of animals against brucellosis in the past, yes.
Yes, previously there was no vaccination program conducted in Pakistan, but now we have started vaccination of at least male animals, male breeding animals.
Okay. All right.
Hello, is it on? Can you hear me?
Yes. of
Okay.
course.
Thanks. What a fascinating outbreak. Through your investigation, have you learned much about how workers have been explained occupational risks? Is that something that people working in this setting, were they briefed on, educated on risks of disease caused by animals before they started work?
No, there is no education of the workers prior to start of their job. No, but now we have started. We have included these few chapters on zoonotic diseases in course contents of AI technicians, and we are also imparting awareness to farmers.
Thank you. Very interesting outbreak. I wonder if you looked at other possible risk factors for Brucella, such as consumption of unpasteurized milk or anything like that.
Actually, the origin of this outbreak was related to male animals. Although there was milking animals, we investigated also that aspect of outbreak, but I'm not mentioning it here as well.
Thank you for your nice presentation. You identified one of the risk factors as lack of protective gear.
Yes.
But in your recommendations, they don't find that.
No,
mentioned.
I have recommended.
Because in interventions which have been this.
I have recommended that use of possible protective measures for the workers and routine screening also.
Are they usually, these workers are wearing these protective gears?
Sorry?
Usually the workers wear these protective gears during the time of
Some
this?
of the workers are wearing, but they are not very strict with using of gloves and masks.
Okay, thank you.
Yeah. Do you have any idea of the cost of some of the recommendations you made, like testing for brucellosis or the mass vaccination of animals and regular? Any idea on the cost?
Previously, we were not doing routine screening of the workers and animals, but for the last 1 year, we have established disease control compartments, and we are doing surveillance and routine screening against brucellosis and other zoonotic diseases as well.
But do you know what's the cost of
Sorry, I didn't understand.
Okay, all right.
The question he's asking is, have you looked at the cost implication of your intervention? You said that all the animals will be screened. So how much it cost, all the interventions you have suggested? Is that
Yes, it is, because some of the things we recommend, we have to be very clear about whether it can be implemented.
Our department has estimated that cost, and that's why they have carrying out a big project on screening of animals.
Right, thank you very much. I think this was a good presentation. So, the next presenter is Frank, Smoking Prevalence, Awareness, and Tobacco Cessation Training among Health Professionals in Yaoundé, Cameroon. So you have your 5 minutes, you can start.
Good evening. So, according to WHO, tobacco smoking is the leading cause of preventable deaths worldwide, and in 2015, smoking resulted in more deaths than HIV, malaria, and tuberculosis combined. In Cameroon, the prevalence of smoking amongst adults, according to the Global Adult Tobacco Survey in 2013, is at 6%, and more than 45% of adults are exposed to secondhand smoke. As role models and facilitators of smoking cessation, it is important that healthcare professionals incorporate positive health behaviors into their personal lifestyles. Thus, our study aimed to determine the prevalence of smoking amongst healthcare professionals, assess healthcare professionals' exposure to secondhand smoke, evaluate their knowledge and attitudes regarding the role in smoking cessation, describe their training and practice of cessation techniques, and identify factors related to smoking status. We conducted a prospective cross-sectional study from February to July 2017 amongst healthcare professionals working in health facilities in Yaoundé, which is the capital city of Cameroon. We performed a multi-stage sampling with healthcare facilities as our primary unit, and all healthcare professionals who were found in the health facility when investigators visited and who volunteered were included. A pre-tested structured questionnaire was used to collect information on demographics, tobacco use, secondhand smoke exposure, knowledge and attitudes, and cessation training. We conducted logistic regression analysis at 95% confidence intervals, and our p-value was set at less than 0.05. Ladies and gentlemen, our results. Of the 945 eligible healthcare professionals, 749 were included, aged from 17 to 74 years, with a median age of 33. The smoking prevalence amongst healthcare professionals in Yaoundé was 6.5%, which is similar to that obtained in the Global Adult Tobacco Survey, which was conducted in 2013. We can note from the graph, the map above, which shows the prevalence of smoking per health district, that the Corbison Health District in red had the highest prevalence amongst the 6 districts where we conducted our study. Over close to 50% of healthcare professionals were exposed to secondhand smoke, and 95% of them were in favor of legislation banning smoking in public places. Majority, that is 97% of healthcare professionals, knew of the harmful effects of tobacco smoking, and compared to smokers, non-smokers were more likely to feel that healthcare professionals serve as role models and that smokers have better chances of quitting tobacco smoking if helped by a healthcare professional. Unfortunately, most of these healthcare professionals had never received a formal training on cessation techniques. And from our multivariable analysis, smoking was significantly associated with the male sex, secondhand smoke exposure in enclosed public places and at home, and equally residing in the Efulan and Corbison health districts. In conclusion, healthcare professionals in Yaoundé smoke tobacco as much as adults in general population, despite the high awareness of its harmful effects. Smoking was significantly associated with the male sex, secondhand smoke exposure, and residing in the Corbison or Efulan health districts. Exposure of healthcare professionals to secondhand smoke in enclosed places is high, and most of our healthcare professionals had never received any formal training on techniques to help smokers quit. We thus recommend a continuous sensitization of healthcare professionals to quit smoking, but equally a training on techniques to help smokers stop. Also, that legislation banning smoking in enclosed public places be elaborated and enforced. In the course of our study, we attempted to address potential recall and non-response bias by using a standardized questionnaire and equally conducting revisits. We would like to acknowledge the United States government for its support on the FETP program and the following institutions. Thank you.
Thank you, Frank. Those with questions can still line up. Just some clarification on the level of staffing at a primary health facility in Cameroon. I know in most of our countries, we have very few people working at the primary level, and they are overwhelmed by what we want them to do. So recommending that they then start doing counseling to get people to quit smoking. I don't know whether you've thought about the implication on, you know, the other services that are already being inadequately provided, or you were thinking about maybe lobbying the government to bring in an additional staff to do that kind of work. Just your comment.
Thank you for that question. So I didn't maybe over elaborate on our sampling, but we didn't focus only on primary healthcare facilities. As you can see, we had primary, secondary, and even tertiary healthcare facilities within the 30 health facilities we selected randomly. And we used the probability proportional size to select these health facilities. So, and the second thing I would like to add is that it's been shown that even a 10 minutes counseling on smoking cessation is highly effective in helping smokers to quit. So even in those primary health facilities, taking a 10-minute period to sensitize your clients could help curb that even at your level.
Yes.
So my question is, you had 2 districts with high prevalence of smoking and the health professionals. So did you look into, like, is there any difference among the health professionals among these districts with other districts? Any demographic or any particular difference you captured in your data?
Thank you. That's a good question. We've been wondering ourselves why those 2 came out. But we would like to note here, it's not very clear, but that those 2 districts that had the highest were mainly found in rural areas. And in the review of literature, we saw that smoking was typically slightly higher in those rural areas. But we didn't try to push. I think it would be a nice line to push on why those 2 districts and why not the others. Thank you.
Thank you. Thank you for the good presentation. I have 2 questions. The first one is, can you comment on the response rate, the 79% response rate? And then the second one is, do you have an idea of when healthcare workers started smoking? When were they introduced to smoking?
Okay, thank you for those questions. I will start with the first. So our response rate, as we can see here, is at 79%. So we tried to make sure that this was as high as this 79% by visiting twice the health facilities where we went to. But equally, in our sample, we accounted for non-response by adding the sample size by 20%. Also, pertaining to your second question, if I get that right, was when did they start? Okay, so we didn't show that here, but we tried to inquire on when most healthcare professionals started smoking. And we noticed that most of them started smoking during their schooling years in med school. So, but that isn't presented here.
Thank you. Just out of curiosity, what is the retirement age for a health worker in Cameroon?
So that will depend on the category of health workers. So, but typically, I'll take a medical doctor, not specialized, retires at 55. And if you specialized, you could go up 60, and a professor can go up to 65.
Because I've seen you, the range is from 17 to 74. Thank you very much.
Thank you very much.
So the next presenter is Mpos Kosara from South Africa. It's a presentation on herpes simplex virus type 1 in the pediatric burn patients in the large tertiary hospital in South Africa. You have your 5 minutes.
Good evening. Immune suppression that results due to thermal injuries can predispose to infections, and it is the degree as well as the extent of the burn wounds that determines the immune suppression. In July of 2017 in Gauteng province in South Africa, 6 pediatric burn patients presented with a febrile illness rash. The rash was maculopapular in nature, and some of the cases also presented with coryza, or a runny nose. And because of an ongoing measles outbreak in the province at the time, measles was suspected. However, in 3 of the cases, the rash then evolved, becoming vesicular in nature, and varicella zoster was now a differential diagnosis. An investigation was started in order to confirm this. The composite case definition that was used in this investigation included any patient who was admitted in the unit during June and July of 2017 who presented with either a maculopapular or vesicular rash with or without fever or coryza. And once a patient met this case definition, the medical records were reviewed, blood, vesicular fluid, and scab samples were collected. This diagram shows the sequence of events during the investigation, beginning on the 6th of July, when the initial 6 cases were reported to the National Institute for Communicable Diseases, or NICD. On the 7th of July, both measles and rubella was excluded based on serological testing. The first visit to the ward was conducted on the 11th of July, and on the 12th of July, the first case with a vesicular rash was reported to NICD. Varicella was excluded based on serological testing in this case on the 13th of July, and a second visit was conducted to the ward where 2 other cases with a vesicular rash were identified. Vesicular fluids were collected, sent to NICD for electron microscopy where a herpes virus was identified. And eventually on the 18th and the 19th of July, herpes simplex virus type 1 was diagnosed based on molecular testing. Table 1 shows the characteristics of the cases in this cluster. The last 2 patients were probable HSV1 cases because they were identified later on in the investigation based on the review of medical records. And at that time, appropriate samples were not available for laboratory testing. This diagram shows the layout of the burn unit. And it also shows the wound dressing room that was shared by all of the cases involved in this cluster. Figure 3 shows the vesicular lesions that were seen in some of the cases. And figure 4 shows the herpes viral particles that were seen on electron microscopy. Therefore, in this investigation, we identified 3 laboratory-confirmed and 2 probable cases of herpes simplex virus type 1. Typically, HSV1 presents periorally, and when it is described in the setting of burn wounds, it's usually associated with extensive full-thickness burns. Therefore, the presentation in this cluster was atypical in that only 2 cases had facial burn wounds. There was only 1 case that had oral labial involvement, and all of the patients had partial burns that were less than 20% of the body surface area. Even though the investigation was concluded, we still could not establish whether this was a case of primary nosocomial transmission of HSV1 or whether it was a reactivation of the disease. Due to the spatial and temporal clustering of the cases, in the sense that all of the patients presented at the same time, that is in the same month, in the same ward, and that they also shared the same wound dressing room, primary nosocomial transmission is likely. However, because of the ages of the cases and the high background prevalence of HSV1 in our setting, reactivation of the disease is also likely. The limitations of our investigation is that we could not conduct sequencing in order to establish that it was the same strain of HSV1 in the cases, and the virus could not be tested for in the healthcare workers and in the environment. Thank you.
Thank you, Paul. Any questions for her? What challenges did you face in trying to test health workers? Was it an ethical issue, testing health workers for HSV?
Sorry, may I just get the question again?
No, you said you couldn't test
Yes.
health workers.
Yes.
So what were the problems?
Well, firstly, the index of suspicion for the disease was low. HSV1 in burn patients has not been described in our setting. So the testing in healthcare workers would also have been logistically challenging in the sense that HSV1 can also be shared asymptomatically. So having to test healthcare workers may sometimes entail collecting a number of samples or multiple samples over a long period of time. And also, secondly, HSV1 doesn't have a vaccine. So even if the diagnosis was established in healthcare workers, I suppose it would mean that they would have to be moved to another ward. But which ward would you move the patients to, the healthcare workers to? Because they would, in essence, be in the presence of sick individuals. So I suppose that was the reasoning behind not testing for it in healthcare workers.
Any other questions for her? Yes, Samuel.
Seymour Williams, workforce. Was an infection control assessment done? You mentioned the table, and that may give you some guidance if infection control is broken down, but was an assessment done?
Thank you for your question. So the only infection prevention control measures that were instituted involved cohorting all of the cases with the vesicular rash. And it was emphasized to the healthcare workers that strict infection prevention control measures, including the cleaning up of the basins or the baths where the patients were washed and the counters where they were dressed, was done. But that was as far as any infection prevention control measures went.
So what happened to these 5 patients?
So luckily, there were no sequelae thereafter. And I say luckily because HSV1 is associated with encephalitis, particularly in young children. So in this particular cluster, all of the children recovered without any complications.
Any other question for her? No, thank you. This is very
Thank you.
interesting. So the next presenter is Mahmoud Riaz. No. Oh, okay. Outbreak investigation of anthrax.
Dr. Riaz, it's actually Dr. Kunar.
Yes. From India. Sorry about that. So you. Okay, you have 5 minutes.
No, it is not mine open.
Press enter.
not taking enter.
Can you scroll down? There we go.
Good evening. Human anthrax is a zoonotic disease caused by Bacillus anthracis. Estimated case fatality rate if untreated for cutaneous is 5 to 20%, for gastrointestinal 40%, for inhalational more than 85%. In India, human anthrax outbreak reported from eastern states including Jharkhand. These outbreaks predominantly occur in tribal community. On August 10, 2017, Gumla district, Jharkhand reported human and animal deaths in Sikoi village. On September 1st, National Center for Disease Control India deployed India EIS officers and veterinary consultant. This outbreak occurred in Sikoi village in tribal community of Gumla in Jharkhand in India. We investigated to describe epidemiology of the outbreak, to determine risk factor and provide recommendation for control and prevention. We defined probable case as illness epidemiologically linked in cattle, to a cattle death in a Sikoi village resident with cutaneous, gastrointestinal or inhalational presentation. We defined a confirmed case as a probable case with laboratory confirmation for Bacillus anthracis by real-time PCR. We searched for cases by reviewing records and doing house-to-house case search in Sikoi. For retrospective cohort study, we defined a cohort as all residents of Sikoi village. Data were collected for socio-demographics, carcass handling and disposal, carcass meat preparation and consumption. We calculated relative risks. We tested blood samples for wounds and wound swabs for real-time PCR for Bacillus anthracis. We reviewed records for wild animal deaths and collected data about anthrax vaccination status and history of livestock death and disposal. We also cultured blood samples from animals and soil samples for Bacillus anthracis. There were 22 cases, median age by 26 years, and 91% were male. Among 22 cases, 19 had cutaneous presentation, but was 1 gastrointestinal and 2 inhalation. All 3 deaths were among the gastrointestinal and inhalation cases and were the main butcher of the community. This map shows distribution of human cases and deaths in houses. All surviving cases shown in yellow and deaths shown in red are clustered around houses that handle dead animals. Most cases were clustered in July and August, including the 3 deaths. The outbreak ended soon after antibiotic distribution to high-risk group. We found illness significantly associated with eating carcass meat and handling carcasses. 1 out of human wound swab was positive for Bacillus anthracis. There were no wild animal deaths. Among 1,174 livestock, none were vaccinated for anthrax. There were 5 cattle deaths and no personal protection were used during disposal. There were no growth on animal blood samples and soil samples. In this map, black triangle shows cattle that were slaughtered for consumption. Blue triangle shows the cattle that were buried but not consumed. Human cases and deaths were clustered where cattle were slaughtered. This graph shows the temporal relationship between cattle deaths and human cases. Most human cases were clustered around the time when cattle were slaughtered. Our investigation is limited by recall bias, carcass sample being not available for testing, and late collection testing of environmental samples. This was a confirmed anthrax outbreak, mostly among males in tribal community. Severe outcomes were among butchers. Illness were associated with carcass meat consumption and carcass handling. There were no vaccination against anthrax among cattle. Because of our recommendation, village camps were organized to detect diseased cattle, risk of carcass meat consumption, and handling the safe carcasses. District outbreak investigation team now included medical and veterinary officers, and animal husbandry department has included anthrax vaccination for in routine immunization for cattle. Thank you.
Thank you, Kumar. Any questions for him?
I will be translating.
Oh, you
Yes, I will be translating for
translating? Okay. Oh, good.
Around the case that was the inhalational anthrax, is that case special somehow?
She got उसमें वही था symptoms में fever था, cough था, and shortness of breath. So I have a provide case definition, and they were epidemiologically linked to cattle death.
Okay, so I guess your question was the symptoms for the inhalation case? Circumstance.
उन्होंने उसको पूछा किया ना, उसकी de-skinning लिया इसलिए
The case who was probable for inhalational anthrax was the one who was a butcher in the community. He had butchered a dead cattle.
Because the necropsy of like that.
Yes.
And he had this. Is it? Do I need to explain more, or did I answer?
Yes. Go ahead.
Okay.
Explain more.
Okay, so the inhalational case was the person who had who was the butcher in the community. There are people in the community who are given the specific task of butchering dead cattle. So he was one of those, and his symptoms were shortness of breath and fever and cough.
So,
and he was epidemiologically linked to the dead cattle.
So, animals butchered in the bush where there are spores of anthrax, or they are killed in I can just explain a little bit how that happens.
Okay, during the butchering process, the spores of the dead cattle will be in the environment, and during the breathing, there is a risk of inhalation.
Okay. All right, go ahead.
Okay, so you mentioned no immunization whatsoever and no personal protective equipment whatsoever. So that sounds like some real potential for making an impact in this kind of community, and it sounds like there's already some preliminary efforts in that regard. So what's the likelihood of getting to some objectives that would prevent this sort of outbreak in the future?
So he said, जो हम लोग बोल रहे थे ना कि हम लोग कह रहे हैं कि पर्सनल प्रोटेक्शन बड़ा रिस्क फैक्टर है, और ये लोग वैक्सीनेशन नहीं है, तो ये सब अगर जो हम कह रहे हैं तो फिर इस तो आगे जो आउटब्रेक्स होंगे उनको प्रिवेंट करना बहुत मुश्किल हो जाएगा. तो आप क्या कहना चाहोगे?
इसके लिए हमने कम्युनिटी एजुकेशन की है कि वो लोग इसको जिनको पहले टीचिंग किया है कैसे आइडेंटिफाई करें, आइडेंटिफाई करने के बाद उनको कहा इनको गाड़ दें, इनको मतलब बूझ ना करें. और तीसरा ये कि एनिमल डिपार्टमेंट को कहा है कि इनको जानवरों को वैक्सीनेट करें.
We realized that these are challenging recommendations, so we emphasized a lot on educating the villagers about identifying animals that are dying of anthrax. We discouraged them from consuming the meat of diseased animal.
I think we made a recommendation about people destroying the carcasses, the dead animals. Is there any compensation for their losses, anything like that, to encourage them to do that?
गवर्नमेंट पैसा तो नहीं देती है, लेकिन हम प्रोटेक्टिव ग्लव्स वगैरह प्रोवाइड कराते हैं और उनको जो साल्ट जब डीप बरियल करते हैं उनको साल्ट वगैरह जिससे कि उनका डीप बरियल हो और साल्ट डालें इसमें, बाकी पैसा तो कोई नहीं देता।
Although the government does not provide any monetary help to procure protective equipment or for the vaccination of animals for anthrax, but during the investigation, we educated the community about safe disposal, which was like digging the deep burial sites and covering it with the salt. And at the same time, we spoke to the district and state administration to make arrangements for vaccination against anthrax among animals.
Okay. Thank you very much, Kumar. Thank you for the translation.
Thank you. Thank you.
So, Mahmoud, you can come up now, I think. So this is the next presentation by Dr. Yaz, investigation of measles outbreak in a district in Afghanistan. If you can find your presentation, this is the one?
Yeah, yeah.
Forget to go out.
Yeah, yeah.
Now you
That's
enter
the
your name and then,
Okay.
Okay. Go ahead.
Good evening. Measles is common in Afghanistan, as are outbreaks. Nationally, only 60% of children have received one dose of vaccine by age of 23 months. In Kunar province, where I work, only 42.1% have received one dose of vaccine by this age. In 2016, we investigated 7 measles outbreaks in Kunar province. In April 2017, a cluster of suspected measles cases were reported from a small community named Watash village of Shiragal area, Afghanistan. This slide shows Afghanistan is landlocked country of 34 million people surrounded by globally strategical important country. Among Afghanistan provinces, Kunar province is at the far east, bordered with Pakistan and China. This is the picture of Batash village, which is located in rural and isolated part of Kunar province. Our investigation had 4 objectives: to confirm etiology of disease, to identify additional cases and risk factor for infection, to make recommendation to prevent future outbreaks. We defined suspected case of any person with fever, mucopapilla rash, and cough crucia or conjunctivitis, and a confirmed case as suspected case with a positive IgM test for measles. We performed a cross-sectional study within the population of 2,136 individuals. We made an initial visit to the site on April 5. One day after receiving notification of outbreak, we selected for in-depth review as cross-sectional convenience sample of 118 children aged less than 15. Children were selected because it appeared that only children were become ill. The 118 was chosen by knocking addresses of reported cases and then knocking on the door of neighbor houses. Among the 118 children, we identified 48 cases. A proportion of 40.7 cases were young and no death occurred. We calculated minimal attack rate among village children using the number of cases in our group of 118 children as numerator and population census estimates of the number of children in 3 age group. Admittedly, this effort is crowded, but showed that the minimal attack rate was highest in children 0 to 5 years of age, 8.7, followed by children 6 to 10, and then 11 to 15 years of age. The cases universally had rash and fever, with one half of more have crucia, cough, and conjunctivitis. This two picture shows the cases were clinical ill. We believe the outbreak began with one index case. This child was from the village and had no travel history, but fled with multiple children in the village. His illness was followed by additional cases with onset over a 12-day period, with the first cases occurring 7 days after onset of illness in the index case, assuming the index case infected all other cases. The mean incubation period was 10.6 days. The last case became ill on April 12. Our vaccination effort began on 9th April, although general control measures were instituted earlier. For example, keep well children away from ill children. We do not know why the outbreak ended. Measles was confirmed by 3 of 4 blood tests being positive for IgM antibody. The history of at least one dose of measles vaccine among our under 5-year-old was 52.5%. Measles vaccine history was protective with a RR of 0.238. among those vaccinated. Although prevalence vaccine rate are supposedly 65% in children, only 52.5% of the children could produce proof of vaccination. We vaccinated 961 children aged 6 to 5 years in Batash village and surrounding villages as per Afghan protocols. Vaccination effort in Afghanistan are very difficult with difficult terrain, isolated and remote villages, limited resources, and religious objection to vaccine. In many parts of Afghanistan, the Taliban are active and pose dangerous to vaccine teams. Last, we have no provincial means of controlling cases, and early the Central Reference Laboratory in Kabul can perform confirmatory IgM testing. Low vaccination coverage was the likely cause of this outbreak. We recommended strengthening vaccination effort, but of course, this is easy to recommend it, but difficult to perform. Negotiating with the community the benefits of vaccination is important. Security issue will continue to impede national vaccination efforts. At last, I would like to thank the multiple individuals and organizations that made our work possible. Thank you.
Thank you, Dr. Yaz. Unfortunately, we've run out of time. I will just ask one question.
Which slide?
The epidemic curve. The epidemic.
Difficult.
The slide that shows the epidemic curve.
Epidemic, yes.
So you had 118 suspected cases based on the clinical case definition. Blood specimens were collected from 4 of those 118. 3 of those 4 were IgM positive, so definitely there was measles present in that area. My question to you is, why do you think the peak-to-peak interval in this epidemic curve is so short relative to what we would expect if this was a measles outbreak?
Yeah. First of all, sorry for language problem. If you can again repeat your question,
sure,
I will be happy.
So, as you're aware, in a disease that's caused by a person-to-person transmission, the interval between the peaks is usually equal to the incubation period.
Yeah.
The incubation period of measles is usually between 7 and 14 days, more or less, although it can go to 21 days. Usually in outbreaks, we see 8 to 10 days interval between the peaks. Here I'm looking at those peaks, and I see, for example, from the 25th of April, there's 6 days, it looks like, to the 2nd of April, and then from the 2nd of April to the, looks like the 6th of April is the interval between the next 2 peaks, only 4 days, much shorter than what we would expect with the measles outbreak. So do you think perhaps that all of these 118 cases may not have been measles, that in fact perhaps something else was going on?
Thanks for a good question. Once I mentioned there was a security problem in Afghanistan, in this area. Maybe I missed some cases in the area due to security issues. And the 2 peaks maybe due to missing of the data and between the two peaks. Okay.
Okay. Thank you very much, Dr. Riaz.
Thank you.
Thank you. We'll move to the next presenter, Claudia.
It's okay, I can do it.
Communicating prevention messages in the digital age using dating applications and mobile websites to reach men who have sex with men during an outbreak of hepatitis A in Berlin.
Thank you very much. Good evening. I'm going to present data on a campaign that we launched on dating apps and mobile websites during an outbreak of hepatitis A among men who have sex with men in Berlin, Germany. And I'm going to start with a brief recap on hepatitis A. It's a self-limiting viral infection of the liver. It's usually transmitted fecal-orally, but sexual transmission among men who have sex with men occurs. The incubation period is around a month, and maximum infectivity is already before typical symptoms like fever, abdominal pain, and jaundice set in. The most important preventive measures in sexually transmitted hepatitis A outbreaks include tracing and vaccination of close and sexual contacts. In Germany, the hepatitis A vaccination is recommended for MSM and insurance coverage. So these are the notified hepatitis A cases in Berlin over the last couple of years, stratified by gender. And you can see that the increase in male cases by the end of 2016 is quite striking. This is when the outbreak started. We count altogether 190 cases, most of them being men who self-declare as MSM, and also many cases reported to have frequent anonymous sexual contacts and use dating apps to meet those contacts. The outbreak is part of a large European cluster that includes more than 3,800 cases. So we came up with the idea to launch a campaign on different MSM dating apps and mobile websites in order to identify the most suitable platforms and formats, but also to evaluate the overall usefulness of those information channels to spread prevention messages among MSM who seek anonymous sexual contacts. But we were also distributing information material directly in the important venues. So we launched the campaign on the 3 most popular MSM dating apps in Europe and also included a bundle of 8 LGBT websites. The campaign was targeted at male users whose device was located in Berlin. And clicking on an advertisement led the user to a hepatitis A outbreak website that we designed, containing information on transmission ways and risk factors, and most importantly, the insurance-covered vaccination recommendations. The campaign ran over a time frame of 3.5 weeks in March and April last year. And we designed the advertisements in different sizes. So for example, this is what a full screen advertisement looked like, but there were also smaller rectangles or narrow banners. An important term in web marketing is the term impressions. This is the number of times an advertisement is shown on a website or on an app. It's basically what you pay for, what you buy when you launch a campaign. We obtained the results for each of the platforms and formats in daily number of clicks and daily click rates. This is the percentage of clicks on the impressions. And we then investigated the independent effects of advertisement format and platform they were placed on the number of clicks by using a negative binomial regression model. So this is the epi-curve of the outbreak. The dark blue bars are MSM. And you can see that we started the campaign on mobile media during the second peak of the outbreak, and then shortly after distributed information material directly in the venues. And And this table shows the results of the campaign in number of impressions, number of clicks, and click rate. And you can see that there are remarkable differences in the click rates. For example, if you take a look at the full screen ads on Grindr, they yielded a click rate 6 times higher than most of the other smaller banners or rectangles, for example, on the websites. So we took a look at those effects in the multivariable analysis, and indeed we found that a switch from websites, especially to the dating app Grindr, yielded a significant increase in number of clicks by more than 9 times. And the switch from smaller banners to full screens also yielded a significant increase in number of clicks. So to conclude, dating apps and mobile websites indeed provided a timely reach of many people with only limited effort, possibly including also those typically hard to reach MSM. We think it should complement classic contact tracing in those kinds of outbreaks, at least when anonymous sexual contacts are involved. However, the campaign's reach, when it's measured in clicks, highly depends on the platform used and on the format of the advertisements. So my recommendations in those kinds of outbreaks: ask the cases about the ways and venues they are seeking anonymous sex at an early stage of the outbreak investigation, and include information on the use of dating apps. If you launch a campaign, carefully consider the right platforms and formats, as those seem to have independent effects on the reach of the campaign. But also combine your campaign with more traditional information channels, such as print media and radio, TV broadcast, and of course distribution of information material in the venues. Thank you.
Very interesting. Are you able to link the media messaging to the outcome on the public health side in terms of increase in hepatitis A vaccine uptake, for example, or anything?
Yeah. Thank you for this very good point. Indeed, my presentation at the moment focuses on the campaign's reach. The other side is the campaign's impact, and this is, of course, much more interesting. We chose 3 approaches to evaluate the campaign's impact. One of them, of course, being the vaccination uptake among men in Berlin. Unfortunately, we don't have the complete data for 2017, but indeed we do see a sharp increase in vaccination uptake in April and May, so that fits pretty good. But it's always hard to assign this to a single measure. There have been, of course, other measures like informing the physicians, and it's difficult to assign this to a single measure, but there is a sharp increase in vaccination uptake. The other approach is, if we look at the course of the outbreak and we compare it, as I mentioned, it is part of a large European cluster. If we compare the course of the outbreak with the ones in other European countries that were also affected, our cases start to decline by April, and in other European countries it was more in August, so a bit later. So this is could also be a hint, the decline of cases. And the third approach that we chose to evaluate the impact was we also performed a survey on a large gay street festival in Berlin happening in July, and asking people whether they had heard about the outbreak and whether they got vaccinated due to the campaign. And 15% of them answered that